Good afternoon, everyone. Hello, hello. If we can all get seated, we're going to go ahead and begin. Welcome, everybody. I'm Delegate Emily Shetty, Chair of the Health and Social Services Subcommittee on Appropriations. Pleased to be joined by our awesome committee counsel, Joe Gottberlet, and our amazing members here today to do our Behavioral Health Administration hearing. We will start, as we always do, with our wonderful DLS analyst, Naomi Kimura, who will present the DLS analysis, after which we'll hear from our Deputy Secretary, Alyssa Lord, and we have 15 advocates signed up to testify after that. So thank you so much. You may begin when you're ready.
Thank you, Chair Shetty. My name is Naomi Kimura. I am the Budget Analyst with Department of Legislative Services. I'll be presenting on the Behavioral Health Administration budget for fiscal 2026. This budget does include 3 different programs for provider reimbursements for behavioral health services in the state. The fiscal 26 allowance includes $3.4 billion for BHA, which is an increase of about $83 million above the current fiscal year. Turning to page 5, begins discussion of a couple of different performance measures that are included in data that MDH submits annually. The first is related to the service utilization in the public behavioral health system. Exhibit 1 on page 6 shows the difference in service utilization from fiscal 2019 through fiscal 2024. Since fiscal 2020, or rather fiscal 2021, the total number of individuals treated by the system has been increasing, which has been driven mainly by a service utilization increase among individuals with mental health diagnoses. The analysis also points out that MDH has indicated that the more modest growth among individuals with a substance use disorder diagnosis could be also related to a dating reporting practice that changed in fiscal 2020, not necessarily a reflection of decreased need or decreased access to care. The second measure discussed in the analysis is related to medication for the treatment of opioid use disorder, or MOUD. Exhibit 2 on this page shows the number of individuals who are service recipients for substance use disorder services in the public behavioral health system, and the percentage of those that are treated with MOUD. On top of page 8 includes discussion with some more detail on MOUD treatment. Earlier this year, the Department of Health received approval from CMS for a waiver that would cover MOUD services for incarcerated individuals 90 days prior to their release. There's $4.4 million in special funds in the budget to support this service, available from the Opioid Restitution Fund. DLS has asked MDH to clarify if these special funds are needed given the waiver approval. The third measure included in this analysis is related to telebehavioral health usage. So the chart on page 9, exhibit 3, shows a pretty dramatic increase between fiscal 2019 and fiscal 2020 in usage. This is mainly due to the expansion of eligibility for reimbursements to providers that are providing audio-only telehealth services. There was subsequent state legislation that required the Department of Health to continue covering the service through June 2025. The next couple pages include fiscal 2025 budget actions. So first, starting on the bottom of page 9, includes some information about cost containment measures taken by the Board of Public Works in July of 2024. I'll just point out the largest one at the bottom of page 9 is a $9 million reduction for the 988 Trust Fund due to the availability of special fund from telephone fee revenue, which went into effect October of 2024. The next page begins discussion of proposed deficiencies. So the fiscal 26 budget plan includes 9 proposed deficiency appropriations for fiscal 2025, which results in a net increase of $97.9 million in fiscal 2025. The biggest deficiency is $149 million related to a shortfall in behavioral health Medicaid services. The next page lists out some negative deficiencies or withdrawals in the fiscal 2025 budget, the largest of which is a reduction of $30 million due to delayed implementation of various behavioral health initiatives. There's also a reduction of $3 million for the 988 crisis line, contingent on a provision in the BRFA, and I'll be discussing that in a couple minutes. The last thing I'll point out on this page are a couple of planned reversions for fiscal 2025. One is of $22.7 million in general funds due to unspent grant funding for local behavioral health authorities in fiscal 24. And then the remaining is $3.9 million for behavioral health Medicaid services in fiscal 2024. The largest portion of the budget in BHA is allocated to provider reimbursements. So the breakout for provider reimbursements is on page 12 in Exhibit 4. That pie chart shows $2.9 billion. So again, a majority of the budget. Most of this is going toward Medicaid services. There's also $19.5 million for a 1% provider rate increase across the 3 provider reimbursement programs, as well as 8% of the budget going towards services for the uninsured population. Exhibit 5 on page 13 breaks out the budget outside of the provider reimbursements. So there's funding for grants for local behavioral health authorities, behavioral health investments that I'll also speak about in a bit. And 16% of the budget is made up of state opioid response grants, which are issued by SAMHSA. Pages 14 and 15 summarize the major budget changes between fiscal 25 and fiscal 26. So again, the entire budget grows by about $82.7 million. This includes $19.5 million for that 1% provider rate increase. There's also an increase of $14.7 million for substance use services that have shifted from the Office of Population Health Improvement to BHA. Some of these increases are offset by a decrease of almost $78 million due to decreased Medicaid enrollment and utilization in fiscal 26.
Ms. Comoro, can you pause for just 1 second? You're doing a great job. Our little room here has never been more exciting and full. I'm so honored to have all of these amazing faces in the audience. I'm wondering, since we have quite a few people who are standing, and I just don't want you all to be uncomfortable, would it be possible, if you see empty seats, can you just squeeze towards the wall so we can make space for our friends here? I just want to make sure that all the seats are utilized and we have an opportunity for everyone who wants to be here to be able to be here. I think we could probably squeeze in everybody if we do that. It's hard to tell from where I'm sitting without my glasses. Look at that, we did it, I think. I think there might be an extra one in the front row, sir, and yeah, perfect. Look at that, amazing, go team. Thank you. This is literally our most exciting hearing, apparently. So thank you. And now back to you, Ms. Comoro, really appreciate it. Okay, and we'll just listen again, thank you.
Yeah, no problem. Okay, so continuing on page 16 of the analysis, Exhibit 7 breaks out the funding received between fiscal 2024 and fiscal 2026 for the state opioid response grants from SAMHSA. The bottom of page 16, moving on to 17, summarizes some of the funding that is received by local behavioral health authorities from BHA. The next section is related to the BRFA. So the Budget Reconciliation and Financing Act does contain 3 provisions related to the BHA budget this year. The first is a provision that would eliminate the $12 million mandate for the 988 Trust Fund in fiscal 2025. The second authorizes transfers from balances of certain health professional boards. There's also a recommendation in the health professional boards analysis that increases the amount of funding that is authorized to be transferred from about $4 million to about $10 million and changes which boards the balances are coming from. And so DLS is also recommending modifying the language on the general fund contingent reduction in the BHA budget to match this amount and the boards that are referenced. The third provision in the BRFA related to BHA has to do with certified community behavioral health clinics. So state legislation requires Maryland to apply to SAMHSA for planning and demonstration grants for the Certified Community Behavioral Health Clinic program. SAMHSA awarded MDH about $900,000 in fiscal 2025, but the department has not yet accepted or declined the award, and so DLS has asked MDH to indicate if any other funding has been awarded for this purpose, and if so, how much. On the next page, the bottom of page 18 begins discussion of behavioral health provider reimbursements. So again, there's $2.9 billion in the budget for provider reimbursements. And this includes $19.5 million for the 1% provider rate increase. Due to the state's financial situation, DLS is recommending deleting the $19.5 million. The next page contains discussion pertaining to the DLS forecast. So twice a year, DLS completes forecasts for Medicaid and non-Medicaid behavioral health services in order to assess the adequacy of the amount budgeted for these purposes. For the non-Medicaid programs, for the services for the uninsured, as well as the community services for the Medicaid eligible population, DLS does not have the data by service level that would help make the forecast more accurate. This has been requested in prior year budget bills from the Department of Health, and so DLS is recommending adopting committee narrative to make this request annual so that the department would submit this data and improve the accuracy of our forecast. Exhibit 8 compares the budget to the DLS forecast in each of the 3 programs. Across all 3, DLS has forecasted an $18 million surplus in fiscal 2025, and therefore recommends reducing $9 million in fiscal 2025 from the community services for the Medicaid eligible population. On page 21, there's a brief discussion about Medicaid fraud, waste, and abuse, which has been of concern to the Department of Health in recent years. In response, BHA instituted a pause on new provider enrollments in certain service areas in order to address the issue. DLS has asked MDH to discuss the impact to date of the pause on the number of fraudulent claims that have been submitted. Page 22 summarizes personnel data in the Behavioral Health Administration. The fiscal 26 allowance includes 254 positions, which is with 5 additional regular positions due to the transfer from the Office of Population Health Improvement to BHA. As of December 31st, 2024, BHA had 41.3 vacancies and a vacancy rate of 18.9%. Page 23 starts discussion of the issues included in this analysis. The first one is related to behavioral health investments to address the mental health crisis in the state. Some of the data information included on this page summarizes data from a report that was submitted in 2023 with fiscal 2022 data on behavioral health services for children and youth. As of the writing of this analysis, we had not received the report with fiscal 2023 data, and so DLS has asked BHA to explain why the report has been delayed. Page 23 and then on to 24 summarizes some of the points in the report, but essentially there's a rising need in mental health services, both for adults and for children and youth. And so the rest of this discussion talks about some different ways BHA is trying to address that. One of the tools they're using is these behavioral health investments that I've mentioned a couple times. The fiscal 2025 legislative appropriation includes $89.2 million for this purpose, and the fiscal 2026 budget includes a proposed deficiency in fiscal 25, which would reduce $30 million of this appropriation. The bullet points on the bottom of 24 onto 25 are the different initiatives that are either delayed or not going to happen, resulting in this withdrawal of $30 million. Many of these are being delayed or not being taken on, rather, due to the availability of other funding sources. The fiscal 26 allowance includes $83.2 million for these discretionary investments, and Exhibit 9 includes the funding plan for fiscal 2026. The funding plan includes about $9.9 million for efforts that are Medicaid services, but were not budgeted in the Q10 Medicaid program, and therefore DLS is recommending reducing the general fund appropriation by $9.9 million, and has asked BHA to clarify why staffing expenditures are included in this part of the budget rather than in personnel. Page 27 talks about the Interagency Hospital Overstay Initiative, which is another source of underspending in fiscal 2025. The fiscal 25 legislative appropriation includes $5 million for the initiative, and the fiscal 26 budget bill includes a withdrawal of $1.9 million in fiscal 2025. On page 28, the top of page 28 has a few different bullet points explaining why BHA underspent in fiscal 2025, including the availability of additional community resources, as well as the termination of a contract that would create additional residential treatment center beds. DLS asks MDH to clarify which community services it anticipates coming online and why this contract was terminated. I'm going to move on to page 29, which begins discussion of the 988 crisis line. So as I mentioned earlier, the BPW cost containment measure earlier this fiscal year reduced $9 million of the $12 million appropriated in fiscal 2025. And then there is a provision in the BRFA that would eliminate this mandate. And contingent on that provision passing, $3 million would be reduced from the general fund appropriation for fiscal 2025. MDH anticipates backfilling this general funds with special funds from a telephone fee, revenue from a telephone fee that was established by legislation last session and that which went into effect in October of 2024. On page 30, Exhibit 10 shows the projected revenue estimated by the Comptroller's Office. So in fiscal 2025, Comptroller estimates that the revenue will generate $13.5 million, and in fiscal 2026, estimates that it will generate $20.67 million. Funding from the 988 Trust Fund supports 6 call centers across the state, as well as other activities related to management of the 988 crisis line. Exhibit 11 on page 31 shows the actual spending in fiscal 2024 from the 988 Trust Fund, again going to the local behavioral health authorities and core service agencies that oversee the crisis line centers. On page 32, this begins discussion of the assisted outpatient treatment program. So legislation last session established the AOT program and required local jurisdictions to implement the program, or for the Department of Health to implement the program in any jurisdiction that did not implement their own. The department has been working to build some of the foundations for the program over the last year or so, and Exhibit 12 includes the work plan and any activities done to date in order to establish the program. And some of the actions they've taken includes hiring a director for the AOT program, taking a look at how other states are implementing the program, and also compiling a set of implementation strategies for local jurisdictions. In fiscal 2025 and in fiscal 2026, $3 million was appropriated in each year to support building up the program. The Department of Health also released an RFP in November of 2024 asking for budget spending plans from local jurisdictions. The deadline was January 31st of 2025, and the department said that no jurisdiction submitted plans by this deadline. In addition, the department said that many of the services included in the AOT program should be billable to Medicaid. We've asked MDH to provide an approximate percentage of services that are included in the program that would be billable to Medicaid. And we've also asked MDH to explain its plan to implement the program, given that no jurisdiction has opted to manage their own, nor has submitted any spending plan to the Department of Health. The fourth issue discussed in the analysis relates to the behavioral health workforce. So legislation in 2023 established the Behavioral Health Workforce Investment Fund to support education, training, recruitment, and retention of behavioral health professionals. And it also required the Maryland Healthcare Commission to conduct a behavioral health workforce needs assessment. The findings of this assessment are summarized on the next 2 to 3 pages. But it found that the Maryland behavioral health workforce is very understaffed as well as underpaid. It came up with 6 recommended strategies to strengthen the workforce, which are listed on page 36, as well as funding recommendations for the investment fund. MDH indicated that it's been developing a work plan to figure out how to implement some of these strategies, and DLS has asked the department to share a timeline for the work plan. Finally, the last issue that I'll be discussing relates to provider payment recoupment and transition to the new Behavioral Health Administrative Services organization. The information included on the next few pages was in response to language in the fiscal 2025 budget bill that restricted funding pending submission of a report. On page 38, Exhibit 13 shows the amount of funding that was to be recouped due to the error with the Optum ASO overpaying providers. Due to a technical issue, the ASO issued estimated payments. The department has been recouping anything that was above what should have been paid out. And so this exhibit shows that about $300.6 million has been recouped out of the nearly $360 million that is left to be recouped. The rest has been either forgiven or referred to the DBM collections unit. The next couple pages describes the transition to Carillon, the new ASO, which went live January 1st of 2025. Given all of this information, DLS does recommend releasing the $250 that was restricted pending the report and can issue or process a letter rather, as long as there's no objections raised by the subcommittee. Finally, on this page, I'll just note something about the funding for the ASO contract. Fiscal 2024, there was $33.4 million budgeted for the ASO contract, and in fiscal 2025, there was $31.96 million budgeted. The fiscal 2025 working appropriation includes contract funds for Optum. The Carillon contract, which is also funded in fiscal 2025, was budgeted in the Medicaid budget under a major IT development project. And so we've asked MDH to clarify why the Optum contract in fiscal 2025, which ended in December of 2024, costs nearly the same amount as a full contract year in fiscal 2024. To close, I'll just review the DLS recommendations. So first, DLS recommended modifying the budget bill language related to the board balance transfer. We also recommended restricting funding pending report on provider reimbursements. We recommended reducing the general fund appropriation by $9.9 million for behavioral health initiatives, as well as eliminating the 1% provider rate increase across the 3 provider reimbursement programs, and recommended reducing the fiscal 2025 appropriation by $9 million for the state-funded Medicaid services. There's also several pieces of annual language that authorizes the department to transfer funding between the behavioral health programs and one program in Medicaid.
Great, thank you so much, Ms. Kimura. Does anyone have any questions for our analyst? No, thank you so much. Really appreciate your thorough analysis. We'll now bring up our MDH team. Secretary Lord, Deputy Secretary Lord, if you'd like to come up, bring whoever else you wish to the table with you, and you can begin when you're ready. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. I want to thank you for the opportunity to talk about the Maryland Department of Health's proposed budget for behavioral health and the alignment of funding to support the Moore-Miller administration priorities to achieve a world-class, high-quality health system that provides whole-person care and treats everyone with respect, compassion, and delivers on improved health outcomes and experience. My name is Alyssa Lord. I have the privilege of serving as the Deputy Secretary for Behavioral Health. I'm here today to talk about the work the department has undertaken to build the behavioral health continuum of care. The department is looking upstream to better meet the needs of youth and their families. On February 17th, the department submitted to CMS the revised 1915I State Plan Amendment. Key highlights from this submission include addition of youth peer support services, increased service capacity to reach more youth, extended plan of care review periods, lowered eligibility criteria to improve access to care, and preservation of the Telehealth Access Act to maintain remote service options. Secondarily, the department is partnering with the Maryland Coalition of Families and Manat Healthcare to develop recommendations through a public-facing roadmap that offers a vision for change for the state's public behavioral health system for youth and their families. With that, I will turn to provide brief highlights of our written responses to the DLS questions. In response to the request for clarification if the ORF funds are still needed given the recent waiver approval enables the department to leverage the federal medical assistance match for these services. ORF funding is still needed for the state share of services. In response to the recommendation regarding the Health Occupation Board revenue sweeps, MDH would like to refer the committee to the testimony from the Health Occupations Boards in opposition of this DLS recommendation. In response to the question if any other funding has been awarded for CCBHC grants, no other funding inclusive of grants have been awarded for CCBHCs. Participation in the Planning and Demonstration Grant creates a significant budgetary obligation for the state to move forward with implementing benefits. Services must be covered for both Medicaid and uninsured and underinsured. As per the analysis, the department estimates that it would cost $227 million to implement and support CCBHCs. In other states, such as Missouri, that have implemented CCBHCs, the annual costs have been $496 million. The department acknowledges the recommendation of the deletion of the 1% provider rate increase with an amount of $19.5 million for fiscal year 26. In response to the recommendation of adopting an annual committee narrative with utilization and enrollment information, the department proposes we will post the monthly ASO data files in the virtual data unit in lieu of annual utilization and enrollment reports to improve the accuracy of regular forecasting activities. This is a practice that already exists in behavioral health Medicaid, somatic Medicaid, and DDA. The department respectfully disagrees with the DLS recommendation to reduce the fiscal year 25 general fund appropriation for the program LO-103 state-funded Medicaid services by $9 million. BHA's second quarter projection shows a $2.1 million deficit after factoring in the negative $3.1 million deficiency item. In response to the request to discuss the impact to date of the pause on new provider enrollment on the number of fraudulent claims, given that providers have up to 12 months to submit claims, the full impact of the pause on fraudulent claims for PRP, PRP Health Home, PHP, and IOP may not be fully realized until December 2026 to allow for full claims run out and conclusions of ongoing investigations. A table detailing all the referrals made since July of last year is included in the department's written testimony. In response to the status of the report on services for children and young adults, the report was submitted on February 24th, 2025, and the department apologizes for the delayed submission. The department respectfully disagrees with DLS's recommendation to reduce the general fund appropriated by $9.9 million for crisis services. MDH acknowledges that the current spend plan for these two items does not account for the federal reimbursement, conservatively estimated at $4.9 million. The BHA funding provides support for these state share costs. Taking this reduction would eliminate state budget support for these initiatives, leaving it unfunded. The department respectfully requests to maintain full funding for the spend plan to account for continued investments in programs that serve youth and families, such as the Behavioral Health and Pediatric Primary Care Program, which has been in existence since 2012, the Interagency Hospital Overstay to address adolescent emergency department and inpatient stays. This is also pending fiscal year 26 legislation in Senate Bill 696 and House Bill 962, pediatric overstays, and investments in programs to address the court-ordered wait list. In response to which community resources MDH anticipated coming online to replace spending in the pediatric overstay program, through a partnership with Brook Lane Hospital, MDH established 7 beds, with an additional 7 beds slated for March 2025. MDH also established 15 adolescent inpatient substance use disorder beds. The department has also invested in rate increases for providers for EPSDT. As mentioned above, enhancements to the 1915I State Plan Amendment, and the billing of school-based mental health services through Medicaid. MDH continues to evaluate the continuum of care for children and adolescents, including residential beds and other levels of care. In response to provide an approximate percentage of services included in AOT program that are billable to Medicaid. At this time, we are unable to generate a firm estimate of this percentage because the volume of clinical services received will widely vary. Within these constraints, MDH expects that over 50% of AOT services will be billable to Medicaid. I would refer the committee to our written responses for a full update on which services are billable via Medicaid. Continuing with AOT, MDH is in the preliminary stages of determining its implementation for a statewide MDH-run AOT program, which will be implemented as a regional approach. This strategy has been devised in part as a result of no jurisdiction electing to implement AOT. Preliminary plans include drafting regulations, developing a staffing plan, program materials, and increasing stakeholder engagement. In response to requests for MDH to share a time for completing the Behavioral Health Workforce Assessment Work Plan, the Maryland Healthcare Commission, in collaboration with the Department of Health and Department of Labor, are engaged in the development of a request for an RFP for a vendor to work with the state on next steps for implementation. It is anticipated that the state will work with the vendor through the remainder of calendar year 2025. The department thanks DLS for the recommendation to release $250,000 in general funds that were restricted in fiscal year 25, pending the submission of the report on the recoupment for provider payments and an update on the ASO transition. In response to the request to clarify why the final 6 months of the Optum contract cost nearly the same amount as a full contract year in fiscal 24, the department respectfully disagrees and seeks clarification from DLS on their analysis related to contractual payments. MDH would like to refer back to our written testimony for the invoices and totals that have been paid to date on the Optum contract. And lastly, the department respectfully disagrees with DLS recommendations to restrict budget realignments. The restrictions proposed by DLS place undue stress on the budgeting process and impede MDH's ability to internally address budget shortfalls. At a minimum, MDH urges the General Assembly to allow for budget realignments within Medicaid programs to include the Developmental Disabilities Administration Community Service. If projections turn and Medicaid or DDA waiver program costs run higher than budgeted, realignment limitations could lead to situations where provider payments are halted if general fund appropriation is fully expended before closeout and we are not able to realign available appropriation from elsewhere in the department. This flexibility is important to maintain moving forward and is especially needed now when budget pressures disallow inclusion of any cushion that would allow for changes in enrollment, utilization, or other drivers. I thank the committee members for their time and welcome any questions.
Thank you so much for your thoughtful responses and for the work of you and your team in this space. As you can see, it's very popular subject matter. So really, really appreciate all of your hard work. I know we have a lot of questions from members, so just signaling to my subcommittee friends that I'm going to go last. So if you have questions you'd like to be recognized, please light up your mic and I will get you. Who would like to go first? Delegate McCaskill? There you go.
Thank you, Madam Chair. Welcome back. So let's flip back to the very beginning of the report. Pages 2 and 3 is which I'll be referring to. First, page 2. All right, bullet 2. Maryland's behavioral health workforce is insufficient to greeting growing needs. So on page 2, it mentions that there are 6 recommended strategies to address our insufficient workforce, such as increasing pay, providing funding for education and training, and improving conditions. My questions. Could you please describe how these recommendations are being implemented and at what time frame?
So thank you for the question. We understand that the role of the workforce, and particularly in behavioral health, is critically important to ensure that Marylanders get access to high-quality services. So as referenced in our testimony, the Maryland Healthcare Commission is looking for a vendor that will help us with the further implementation and recommendations.
Okay, perfect. Let's flip over to page 3. The recoupment of provider overpayments and transition of new ASO. So on page 3, it mentions that MDH has recouped or forgiven all about $7.1 million of the total $359.6 million in overpayments stemming from the old ASO. How much has been recouped versus forgiven?
Yes. Delegate McCaskill, it's good to see you again, as always. So I will say, I mean, this is a response into the previous administrative service organization and the estimated payments that were sent. Related to that particular number, I don't know the number of forgiveness off the top of my head. There was an opportunity provided in the 2022 time period for that to occur. I don't know if it's in the analysis or we can get back to, but that certainly was something that occurred. What we worked on with the provider community was those estimated payments negotiated by the previous administration were up at the end of 2023. We provided providers an additional 6 months for providers who had not paid back those payments owed to the state through June of 2024, interest-free from that time period. And then for any provider payments that were not recouped at that time, those were sent to the Central Collections Unit. It was around $36 million, if you will, that was sent to Central Collections at June of 2024. I will say that Central Collections, since that time period, over the summer and the fall, has been working on recouping the remaining payments at $36 million that was left. I don't have the number in terms of their status on that, but they have been actively working on that.
Perfect. Madam Chair, could I please ask one last question? I want to flip over to page 29, just pulling out, down in the last paragraph, and it's in reference to 988. And so DBM indicates funds may be added either by supplemental budget or the budget amendment. I understand that the fees weren't collected till 3/4 or so through the year. And so I'm just curious about 988. Is there any thought around perhaps a supplemental budget to pull those fees out?
Yes, ma'am. So we received confirmation from DBM today that the 988 funds will be in the supplemental budget.
Perfect. I am so excited to hear that. Thank you so much. Thank you, Madam Chair.
Perfect. Thank you. That's great news. Thank you so much. Delegate Heimbach.
Thank you, Madam Chair. At the top of page 24, talks about how the need for high-intensity services among youth and adults has increased. And then it goes on to say that in FY24, BHA released its white space analysis that I guess identified gaps in service. And I'm just curious, can you give us a couple examples of what those gaps were and what kind of corrective action was taken to fix those gaps?
Sure. So if I may take a step back, in 2022, and we've now done this annually, we have constructed the behavioral health continuum of care, and what comprises that is looking at basically the who, what, where, when, why, and how of how services are being delivered across the state. So we look at claims, we look at utilization, we take a look at what programs that we're funding through state general funds or federal funds, and then we've mapped this across the continuum to reflect the lifespan as well as the level of intensity of need of services. And what came out of that is the white space analysis, which we're happy to send to you if you'd like to take a look at it, which basically says where are we offering services and where are we not? And then what is the funding mechanism by which those services are being deployed? And what we found, and as I referenced in my preamble, was that there was a lack of a foundation of services for our youth and our families. And that led to about a 6 to 9 month stakeholder engagement process to learn what were the challenges of accessing services for youth and families that are in need that could benefit from home and community-based services. So with that, it has led us to the revisions to the 1915I, which will allow for youth peer services. It will open up the eligibility so that there aren't as many assessments and evaluations. It lowers the scoring criteria. And then it allows also for lowering the threshold by which documentation and paperwork needs to be completed so that we can actually move families through the services that they need easier. And so that was one of the key pieces that came out of that white space analysis, was the recognition that we need to do more for our youth and our families.
No, thank you for your thorough answer. I'm just curious, has that trend for demand services continued, or is it kind of leveled off, or?
No, as evidenced by our utilization, we have seen an increase across the board for behavioral health services, and we've seen this increase since the pandemic. So it is across the lifespan. We've seen particular increases in all levels of residential SUD or substance use services, and we've also seen increased utilization in our psychiatric rehabilitation programs.
Yeah. Thank you, Madam Chair.
Thank you, Delegate. Thank you, BHA team. Recognizing the Vice Chair for questions.
Thank you so much, Chair. Thank you so much. I would like to flip to Exhibit 6, which is on page 15. Well, 14, it starts in 14. I'm going to page 15. The second, on page 15, the second section in bold is substance use treatment, recovery, and harm reduction. The second to last item there in this section, substance use treatment, recovery, and harm reduction, there's a line that reads, reduction in behavioral health pediatric primary care program. The proposed budget reduces this program by about 1.7 million. So first, for the record, please, what is the behavioral health pediatric primary care program? Let's discuss that. And then why is there a proposed decrease in this funding?
Thank you, Vice Chair, for the question. So happy to talk about the behavioral health pediatric primary care program. So what that does is that integrates behavioral health into pediatric primary care practices. So it may allow for social workers to be embedded for the practices. There are statewide consultation and hotlines that providers can call into to identify resources, collaborate with their peers, and it has been in existence for more than a decade, and it has been a pivotal program for supporting how we think about moving behavioral health services into primary care. So we're treating youth as a whole person. And then in relation to the 1.7, so it is actually not a reduction. We are working with DBM to understand what happened, but what I have said in our testimony is that with that remaining $4.9 million, we would like to be able to utilize that funding to help support the maintenance of the BHIP program.
Okay, so it's not a reduction.
It is not a reduction. We do have no intention of eliminating the BHIP program.
Okay, thank you. Okay, the very next section down, public behavioral health system, the second line item. Last year, the value-based purchasing pilot program funding was not appropriated in FY25. It was a cost containment measure. This year, it is added back into the budget to the tune of $600,000. Can you remind everyone what is the value-based purchasing pilot program, and how will the $600,000 be utilized?
Yes, so thank you for the question. So we will be releasing an RFP for providers to be able to apply in Q4 of this year. So the value-based purchasing pilot was legislation that was passed, I believe in 2023, that identified opportunities for behavioral health providers to participate in incentive models or alternate payment methodology that helps to move the state towards improving quality and outcomes and getting paid for those improvements and services.
Thank you so very much. Thank you, Chair.
Thank you, Madam Vice Chair. Delegate Ruff for questions.
Thank you, Madam Chair. And thank you to the panel. I wanted to start with the medications for opioid use disorder and reentry waivers on pages 7 and 8. It talks about the program administering the medications for opioid use disorder. I see in the analysis that that programming, that service is available in detention centers. Are they available at all Maryland detention centers? And are they also available in prison settings for people who are post-trial? And if, why not? What's the kind of philosophy behind it?
So thank you for the question, Delegate Ruff. So there is legislation. It is, if I remember correctly, House Bill 116 that was enacted in 2019 that required detention centers to implement MOUD or MAT services. And so, yes, MOUD services are available in all detention centers. There is not necessarily a standardized model of care, but it does exist. And then in terms of your question related to aftercare or transitions of care post-release and being able to maintain MOUD or MAT services, yes, sir, that is part of the programming.
No, so I'm making the distinction between detention centers, which is a pretrial facility, versus a prison, which is a post-trial facility for folks that were convicted and sentenced. And so I'm trying to figure out, is there no distinction in that legislation? Are you saying that this
that
service
was just for detention centers, my
right? So
apologies.
what I'm asking about is, what about prisons?
Yes. Well, Ryan, do you want to?
Yeah, so I think also you're referring to page 8 on the good to see you, Delegate Ruffin. Thanks for your question.
You too.
So in the analysis related to the CMS 1115 waiver, so the opportunity is, I think Maryland became the 13th state, I think I have that number right, that applied for a waiver program that would allow for really 3 key components of Medicaid reimbursement within state facilities. So that's a key distinction there. And I'll talk a little bit about that in a second. But the 3 components are Medicaid coverage for case management services, for 30-day prescription drugs, and medication-assisted treatment, to your question. So we are standing up that program in terms of particular phases. Phase 1 is all state facilities. Baltimore City unique in that regard, right, because of that being through corrections and public safety. There, in the waiver request, we've denoted phase 1 versus phase 2. Phase 2 would then go out to local facilities in terms of the jurisdictions that you're talking about to pick up all other particular sites. That work would need additional funding in future fiscal years. The ORF dollars that are in here is for that they're all state-run facilities. Now, I will also say that we are working very closely and happy to follow up with your question in terms of the specific sites that you're mentioning. We're working very closely with corrections and public safety on those state facilities of an implementation and operational plan. That does need to be approved by CMS as well before we start. We're hoping in some sense to get something up and running in fiscal year 2026, pending approval with that, and these are the fundings to do that, and we're happy to follow up online in terms of the specific ones that we're thinking about with the state.
Okay. And then I think what you were talking about was the reentry waiver program.
No, that's actually what I was talking about.
Okay.
Yeah.
Well,
Yes.
I guess we're all talking about it. I'm trying to.
We're covering our ground somewhere.
Make sure I'm clear. Can you just explain is there care coordination assistance after release?
Yes. Okay. So the opportunity there is Medicaid coverage pre-release, but the idea is that once you start 90 days pre-release, is that you would provide additional community supports or handoffs in the community supports to support that. And obviously, data, literature, et cetera, proves that to be an effective model.
Okay. The budget recommended actions on item 4 and 5, as to number 4, there's a recommendation to reduce the general fund appropriation for behavioral health investments due to the inclusion of funding for services that are billable to Medicaid. How confident are you that those services will be covered by Medicaid? And that's on page 3 of the analysis.
Those are the, as my phone a friend next to me is reminding me, those are the crisis stabilization services, and those are already covered by Medicaid.
Okay, perfect. Everybody needs to be able to phone a friend. And then as to item 5, getting rid of the proposed 1% provider rate increase, from the departmental perspective, what could be the potential impacts of not allocating funds for that rate increase?
So the budget as proposed in terms of the governor's budget does propose a 1% increase, recognizing that rate increases are due to support provider adequacy and building out provider and access to Medicaid participants. So we understand, that the tough budgetary decisions in terms that we're all discerning and making. We acknowledge DLS's recommendation related to that, but we would note, right, that the governor's budget as introduced does include a 1% to sort of align with the particular goals of ensuring access for Medicaid participants.
Okay. The last set of questions I have is related to the CCBHCs. Would you agree that CCBHCs provide the state with significant cost savings based on the model of the services they provide?
We have not conducted an analysis to forecast what we think the potential cost savings would be. When we have looked at other states to glean insight, we are seeing wide variability as to how those cost savings are being calculated. It is something that we are continuing to look into to understand. What we do know from other states, and even what we've seen with the 4 CCBHCs that we have in the state of Maryland, they have increased access, but in terms of decreasing total cost of care and improving health outcomes, that is still a question that I think is still pending across a number of states.
So, yeah, we were looking at some of the other states that have implemented this. So in New York, there was a 61% decrease in the number of clients using inpatient services and a 54% decrease in all-cause readmissions. So their investment is yielding a net positive impact on the state budget, according to those numbers. I think that Maryland CCBHCs have reported similar reductions. So did you collect the Maryland program's outcome data to calculate hospital savings before deciding that Maryland could not afford to pursue these programs?
I think we'd like to take the question for the record and get back to you.
Okay.
Thank you. That's good. Did you have a follow-up question?
I had one other, but
Forgive me.
I think we'll probably just take the CCBHC questions offline. But I do kind of want to know what your position is on the BRFA provision to get rid of the, it's the Chapter 275 Act of 2023. And we can talk offline about that too, if that's necessary.
Yeah, we're happy to continue to talk. I mean, I think the recommendation that's as proposed is, again, we all recognize that we're in tough budgetary obligations. While, as you may cite from other states, I agree with Deputy Secretary Lord, additional discernment and research needed in terms of figuring out its longer-term outcomes. We absolutely know that there would be an upfront investment in terms of the state to make for CCBHCs. The department has modeled that out for fiscal year 27 of what that upfront investment would be. If there were longer-term savings over the course of time, those particularly would be felt, we think, in longer future years. And so this is an opportunity to say our department perspective on that is that it does create a significant budgetary obligation in terms of that particular investment, and we've modeled out what those particular numbers would be. And our recommendation is related to ensuring in terms of budgetary savings for that in fiscal years, given the budgetary outlook that we're in.
I understand that. The certified community behavioral health clinics in other states, though, have been secured for what it seems like maybe 2.5 times less the amount of money that the department is talking about having to spend. So I think we should talk about why that difference exists and how we can lower that gap.
We're happy to talk about that. We're also happy to share with you some of the estimates from other states and the actual real experiences from other states that we've talked to, but happy to follow up on that.
Sounds good. Thank you.
Thank you, Delegate. Thank you, team. All right, I'm going to kind of get into my questions now, if I may. So first, I want to take a moment to thank your team for being so committed and at the table in every discussion that's been had on pediatric overstays as well as competency restoration. Those are issues that there have been years of meetings on trying to figure out what the best approach could be to address these extremely complex, difficult issues. So, so most of my questions are related to those. And I want to talk first about assisted outpatient treatment and give an additional thank you in absentia to Chair Pena-Melnick and Subcommittee Chair Bagnall for their work on this issue. So on pages 2 and 3 of the DLS analysis, it mentions that no jurisdiction has opted to establish its own AOT program, which we know was part of a requirement as part of legislation, and then a deadline was given to opt into this, and if it was missed, then the department could step in and establish these programs for those jurisdictions. So I want to thank you for your detailed testimony and ask if you can share if there have been any additional pain points in implementing the plan, but specifically, I see that on page 11 of the analysis, you all have indicated that you plan to cancel approximately $25.6 million in federal funds from FY24. So I want to ask if you can just talk a little bit about why those funds were canceled as it relates to this issue, and whether any of those funds included AOT funds. Could we potentially look to reduce some of the reduce some of the allocations or shift over some of the allocations that you're planning to revert to the general fund into this purpose so that the department has the flexibility to really implement an AOT program successfully statewide?
Thank you for the question, Madam Chair. I think we need some further clarity from DLS that we're canceling $25.6 million in federal funds.
DLS.
So, so on page 11, this is that $25.6 million in federal funds is not actually included in the budget plan, but DBM indicated that this would be a planned reversion that the Department of Health was planning on taking. So that's where that came from. And it relates to fiscal 2024 behavioral health Medicaid services, so it wouldn't be related to the AOT program.
Right, and so thank you. So the question is, instead of reverting funds, can we divert funds to either from prior budgets or from the FY25 planned reversions or FY26 so that they can be used now that we know that none of the jurisdictions have stepped up? Can we use any of the existing resources we have to implement AOT statewide?
So I think we'll need to take that for the record and follow up with finance and DBM to see what options may exist.
Okay, that would be great. Thank you. And if, as you're having those conversations, you can let us know whether any legislation is needed to enable you to do that. Let us know by, I guess, Monday is the rule of the day. Would really appreciate that. So now more specifically to competency restoration issues. So again, I want to do another shout out to Chair Pena-Melnick as well as to Chair Klippinger for leading a lot of those discussions. And thank you again to you and your team for being involved in every step of it. I know we heard actually in our last budget hearing in appropriations just an hour ago about the wait list, the 200 people that are on the wait list, and for competency restoration, and the challenges that BHA is having in staffing beds that are available, so that we could potentially make some progress on actually lowering that list number. So I want to talk a bit about, on page 24 again, in the planned reductions due to delayed implementation projects. So I'll give you a moment to get to the page. So I have very specific questions drafted here. So there's a $10 million project with MedStar and Adventist to support additional tertiary beds that is indicated to have a planned reduction, and a $2.5 million for identifying alternatives to incarceration for individuals with behavioral health challenges. So given some of these challenges we're having on hospital overstays and the competency wait list, how do we work towards getting these programs online sooner so that we can help meaningfully put a dent in that list?
Well, we'd love to, but as outlined in the budget, it's a proposed deficiency to reduce the budget by $30 million. And so if that reduction is taken, then it limits our ability to move those projects forward.
Okay, got it. I think I misread that, so that's helpful. That's helpful clarification. Thank you. And then separately or relatedly, on page 26, there's a line item about hospital discharge, RRP community expansion. Could any of that funding for the 35 new RRP beds be used for either hospital overstay patients or competency restoration list?
So those beds were implemented to support hospital discharge initiatives. So that expansion is tied to decanting our forensic facilities to create capacity.
Okay, got it. So that then we can have more beds at places like Perkins, for example, for the competency restoration.
That's correct.
List. Perfect. That's helpful. Thank you. And then I want to speak to now the Interagency Hospital Overstay Initiative on treatment center beds, please. So thank you for responding to the GLS inquiry on page 28 about the community resources to address hospital overstays in your testimony. So I want to continue that conversation really quick. So in your testimony, you mentioned that 7 more beds at Brook Lane will be coming online next month. I know you referenced it in your oral testimony as well. Are those still on track to be opened in March?
That's correct.
Amazing, great. The more beds, the better. I also want to layer in page 15, the proposed budget change and the reduction in the overstay initiative by $738,000. So do we have confidence that the 1915 waivers and the increase in beds is sufficient when we're still hearing a lot of concerns about hospital overstays? Are we going to be able to address all of these problems?
So it is a seemingly simple sounding question, but very complex, as you know, right, Madam Chair? So per my testimony, we are looking at all levels of care, because what we've done is we've talked about the front end, which is community-based services, and then we've talked about some of the more restrictive levels of care, which are residential treatment centers. Mm-hmm. And so some of the areas that we're focusing on, not only within the department, but also with some of our sister agencies, is how are we building capacity in that middle ground, right? So that the pendulum doesn't have to swing one way or another for youth to get services. So that work is currently underway.
Okay, that's super helpful. Thank you. And I'm just going to flag here, because now we've kept you on the panel for a while, and I know there are many advocates waiting to testify, but we're going to follow up by email with questions related to personnel vacancies, related to Appendix 2, the bed registry and referral system, major IT projects, and some specific questions on Appendix 4, the object fund report. See some very significant increases there. So we want to make sure that we are able to get some thoughts on why that might be. So we don't need to do that right now. We appreciate the opportunity to have you here before us. As always, you all are welcome here. Seeing no further questions from subcommittee members, I appreciate it. This panel has concluded, but as we always ask, please stay for our advocate testimony. We have 15 people signed up, which is so exciting. So thank you. So for advocates who are on our following panels, I am going to call you up 4 at a time in the order in which you are listed in my list here. So we will start with Nicole Grainer with the Community Behavioral Health Association of Maryland, followed by Jeffrey O'Neill with Brook Lane. Next, Michelle Grigsby, and Megan O'Brien with Every Mind. Do we have all 4 here? Great. Okay, so you can go ahead when you're ready. Thank you.
Thank you. Good afternoon, Chair Shetty, Vice Chair Jones. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. We represent 87 providers delivering essential mental health and addiction services across Maryland's public behavioral health system, many of whom are sitting behind me. And I just want to take a quick second and thank all the advocates who showed up. I think it's no surprise that this room is full. This is really important stuff that we're talking about, and we really appreciate them taking this time. I'm here today to urge you to prioritize the full implementation of the Certified Community Behavioral Health Clinic model and protect the 1% rate increase in the governor's budget. This is not just about securing funding. It's about addressing the critical workforce crisis in behavioral health and ensuring Marylanders get the integrated care that they need. You heard the recent Maryland Healthcare Commission report revealing that Maryland has only half the behavioral health workforce that we need to meet demand. Projections show that up to 45% of that workforce is going to leave in the next 3 to 5 years. Maryland's compensation for these workers lags behind neighboring states. The 1% rate increase, though modest, is crucial to retaining our workforce and ensuring continued access to care. Like Delegate Ruff, CBH welcomes the opportunities to better understand MDH's CCBHC prospective costs. Maryland is projecting year 1 costs at roughly double 3 other states and 10 times higher than New York. We know Maryland can also control costs with a smaller number of clinics. The CCBHC model offers a solution. It's not just a funding initiative. It is a proven, comprehensive approach that integrates mental health and physical health care, provides around-the-clock services, reduces reliance on costly hospitalizations. The 6 CCBHCs already operating in Maryland have been successful in improving outcomes and expanding access to care. In December, the Department of Health was awarded over $900,000 in a federal planning grant from SAMHSA to support CCBHC development, but now they intend to turn down that critical funding. We cannot afford to step back from this opportunity. We also urge the committee to give the incoming health secretary, may I finish? Sorry. Thank you. We also encourage the committee to give the incoming health secretary an opportunity to evaluate the efficacy of the CCBH model herself before moving away from a proven integrated health model that's been in place since 2018. We are at a crossroads. If we don't act, we risk losing more professionals, straining the system, and driving up healthcare costs. Please protect the 1% rate increase and fully implement the CCBHC model. Thank you.
Thank you. Next, please.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity to speak. My name is Jeff O'Neill. I'm the Chief Executive Officer of Brook Lane. We're the 2nd largest psychiatric hospital in Maryland and the 2nd largest cache of child and adolescent beds. I've heard it repeatedly said in this meeting already that pediatric overstay is one of the biggest problems that we're dealing with. I'm here to give kudos to the Behavioral Health Administration for embracing an innovative idea and supporting Brook Lane to create 7 beds which addresses this problem directly. We've created a 7-bed residential program at Brook Lane. These children are stuck in hospital ERs, 100% of them, and they were sent from those ERs to our residential program, where they also attend school on campus. They also get socialization in the community. They can even go on passes when appropriate, home to their families, and we've had great success. I provided written documentation on the program for your review on the outcome. Unfortunately, this is a program, these 7 beds are up to be cut. And if they were to be cut, they would be converted to 7 additional inpatient beds, so we could still utilize them. But it doesn't provide the pipeline for these kids to get out of hospital emergency rooms. It only adds additional secured space for them to stay. So it is without hesitation that I strongly advocate for this program, and also point out that every placement into this program was done through the Behavioral Health Administration. So Brook Lane does not cherry pick. We get the most difficult kids in the greatest need. Thank you for your consideration of this program and for continuing to fund behavioral health.
Good afternoon, Madam Chair and committee members. My name is Michelle Grigsby Hackett, and I'm the CEO of Affiliated Sante Group, one of Maryland's largest crisis response providers and outpatient mental health providers in the state of Maryland. I am here today to urge the protection of 988 funding, as well as for funding for mobile response and stabilization services. 988 is a vital resource for Maryland's mental health crisis, and over 40 trained counselors with Sante's call centers have provided critical support to individuals in need. Without the funding, numerous trained counselors will lose their jobs, wait times would increase, and emergency departments will further be overwhelmed. Just for an example, we had a mother call 988 for their 20-year-old son who was in crisis. When we received the call, law enforcement was already involved due to risk behaviors. Our 988 counselors, as well as our mobile crisis teams that were dispatched by 988, were able to de-escalate the crisis and develop a treatment plan. And instead of a law enforcement outcome, the young man was able to return home safely with his mother. Without 988 and mobile crisis services, this case could have ended differently. Urging the General Assembly to authorize the 988 telecom fee to sustain operations is essential, and we're glad to hear today that that will be put in place. Additionally, mobile response and stabilization services, also known as MRSS, has been in effect since 2021 through funding. It is a youth and family crisis service model, and Sante provides that service on 5 counties on the Eastern Shore, which has reduced emergency room visits, hospital admissions, and juvenile justice involvement. Just 2 years, we've been able to divert 381 from law enforcement, 140 youth from emergency petitions, and 137 youth from emergency departments, with connecting 1,000 individuals through stabilization services. Please protect those funding for those services, and we thank you for your time.
Thank you, ma'am. Next, please.
Good afternoon, Chair Shetty, Vice Chair, and subcommittee members. My name is Ariel Gordon, and I'm the director of the Hotline Program at EveryMind. We're a nonprofit organization that has provided critical mental health support and services in Maryland for over 65 years. EveryMind operates the Montgomery County Center for the 988 Suicide and Crisis Lifeline. We serve as the backup 988 center for Prince George's County, and we're one of 3 988 chat and text centers for the state. Today, I'm here to request that 988 call center services be fully funded in FY26. The 988 Lifeline is a critical resource for Marylanders with mental health and behavioral health needs. We provide immediate, anonymous, and confidential support to individuals in distress. The demand for these services increased after the Lifeline launched in 2022, and during that time, call centers like ours have instituted new technology, expanded expanded our teams and increased our training and quality assurance to ensure that we're available to answer every call from someone in need. Last year, we responded to 842 visitors aged 0 to 12. In FY25, we've already responded to 477 young people aged 13 to 17. These are young people who could be texting from their school cafeteria or from their bedrooms late at night looking for someone to listen. More than 2,000 of our visitors last year were people concerned about a friend or a loved one. They're searching for a way to help and often struggling with their own mental health because of the stress that they're juggling. Despite the need, complete funding for 988 call centers until what we've learned today had not been fully secured for fiscal 26. The 988 telecom fee is expected to generate 25 to 30 million annually, and we're asking that the subcommittee authorize expending these funds. Thank you for your time, and thank you for your leadership on these issues.
Thank you all so much for the important work that you're doing to provide services to Marylanders across the state. Questions from the subcommittee? Okay, thank you so much. I'm going to go a little bit out of order because our list had some duplication. So I'm going to ask Dan Martin with the Mental Health Association of Maryland, Kimberly Gordon-Achebe with iMind Behavioral Health, and then I have 2 people with NAMI listed, Michelle Gray and Jeffrey Schultz. Are there 2 people from NAMI here to testify? Yes, okay, so we'll have you all join. That will be the next panel. Thank you, and you can begin.
Thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in support of full funding for the Behavioral Health Administration. BHA is really doing great work and making the investments necessary to improve Maryland's continuum of care for mental health and substance use. Really thrilled with all the work that they're doing to build out Maryland's crisis response system and their system of care for children and youth with serious behavioral health needs. And we're thrilled that they put aside money for the FY26 grant, budget for the crisis response grant program. We're thrilled today to hear that 988 is going to be fully funded in a supplemental. And we're really thrilled about the progress that they've made expanding community-based wraparound programs for children and youth with mental health needs. So 2 things that we're requesting of this subcommittee. Number 1, as my colleagues have said before me, please preserve the 1% increase in provider reimbursements. You heard the workforce data. The workforce today is 50% smaller than necessary to meet today's need, and 45% of the workforce is expected to leave the field in the next 3 years. And we have this data thanks to legislation that you all passed in 2023. And we're grateful that BHA is developing a report to act on the strategies outlined in that report. But we would be taking a step backwards before we even got that plan if you all cut this rate increase. Providing competitive compensation is the #1 recommendation in that report, which is no surprise when many folks in the behavioral health workforce do not even make a living wage. The number 2, we'd ask you to allocate, as my colleague, Ms. Grigsby Hackett said earlier, allocate $5 million to maintain existing youth crisis response capacity. That MRSS program that she talked about is currently being delivered to 11 counties in the state, filling huge gaps in Western Maryland and on the Eastern Shore and in Southern Maryland. It's a key tool in state efforts to reduce avoidable youth psychiatric emergency department visits, unnecessary hospitalization, and preventable criminal justice involvement. And so we'd ask you to continue that. And just your indulgence really quickly, we'll see you tomorrow for the BRFA hearing so we can talk about school mental health then. But I just also wanted to recognize, as you did, Madam Chair, how packed this room is with everybody with their protect mental health funding buttons. This is a really important issue. It hits so many people all across the state. And so we just ask you to do everything you can to preserve funding for these needs.
Thank you so much. Just to clarify, you 2 are with NAMI, right?
Yes, ma'am.
Okay, and then I just want to make sure I called Kimberly Gordon-Achebe. Is Kimberly here?
So Kimberly is not here, but I'm here to represent iMind. I don't know if
You can come up.
Oh, okay.
That's fine. Yeah, we'll start with the NAMI folks while you settle in. Okay, thank you.
Thank you, Madam Chair, Madam Vice Chair. My name is Michael Gray. I'm Deputy Director of NAMI Maryland. NAMI Maryland represents over 58,000 families and individuals impacted by mental health conditions around the state. There are 11 local affiliates and our state office. And I'll be brief because I want everyone to hear what Mr. Schultz next to me has to say. Again, I'm deputy director, I'm staff at NAMI, and I'll tell you, big picture, our members are scared. When the budget, when the board came out, people were scared. They're telling us they're terrified. They're going to lose funding for things like 988. Thank you, Deputy Secretary, for what you said about the supplemental budget. That's great news. That money will be appropriated. But overall, people are worried about losing services. Dan Martin mentioned the Medicaid reimbursement rate. It's all important. Every dollar spent in that budget means services for people impacted by mental health conditions. But again, Mr. Schultz is here as a volunteer, a stakeholder, a NAMI member and advocate. So that's my time. Thank you so much.
Good afternoon, Chair Shetty, Vice Chair Jones, and members of the committee. Thank you for this opportunity to speak today. My name is Jeffrey Schultz, and I reside in Chester, Maryland. 12 years ago, my life changed forever. My appreciation for the Bay Bridge changed, and I had to learn to live the rest of my life without my 23-year-old son, Philip, who after several years of alcoholism and extreme depression, died by suicide. I've taught senior high Sunday school in Severna Park for 30 years. The incidents of suicidal ideation, attempts, and suicides among our youth are both frightening and unnecessary. But like our family, many struggle to find appropriate mental health treatment. It starts with those in crisis. That's the purpose of the Mental Health Helpline. I'm dedicated to volunteering for NAMI, AFSP, and serving for other mental health causes on the Eastern Shore and around the state. Every time I speak or do tabling events like Pride Day, Juneteenth, school health fairs, or the Out of the Darkness Walk, which I chair in Easton, I always stress awareness of 988. The federal government mandated 988 helpline and the states to fund it. I've advocated for, I'm grateful for, and I'm proud of Maryland for the previous commitment to our neighbors in crisis by funding 988 in the last 3 years, and I appreciate what we've heard today. The steadily increasing use of 988 has not only put people in crisis in touch with trained mental health providers, but also considerably reduced the volume of 911 calls. Budget cuts are needed, but not something as important as 988 that is working as it should and saving Marylanders' lives. 988 has a dramatic positive influence on families, committees, and our workplaces, resulting in a healthier, safer, and more prosperous Maryland. What could be better? Thank you.
Okay, thank you. Good afternoon, Madam Chair and members of the committee. My name's Stephen Flynn, and I'm the CEO of iMind Behavioral Health. We are a mobile crisis response team provider in Prince George's County, Maryland. In 2024, our teams had a total of 2,900 crisis calls with over 1,000 calls involving children and young adults under the age of 24. Our response spans from initial call to resolution, typically under 100 minutes, with clinicians spending an average of 45 minutes with individuals in crisis. We operate 24/7 between our various teams, with 40% of our calls occurring in the evening and 12% overnight when no other services are available. We strongly support MDH's decision to include funding for the crisis response grant in their allocations to the local behavioral health authorities. This $5 million in funding is critical to sustaining mobile crisis team services. Our grant award amount of $733,320 helps cover essential components that are not billable through Medicaid, including pre-dispatch preparation, transit times to crisis locations, and overnight services. Without this grant funding, we would need to significantly reduce our capacity to respond to community crisis. I urge you to maintain the 1% provider rate increase, support the $5 million for the Behavioral Health Crisis Response Grant, and authorize expending the 988 telecom fee funds to support 988 services projected at $13.5 million in fiscal year 25 and $20.7 million in fiscal year 26. These critical services reduce emergency department use, prevent unnecessary hospitalizations, and save lives. Maryland has built a strong behavioral health crisis system. By acting on these requests, we can safeguard Maryland's crisis continuum and ensure every resident experiencing a mental health crisis has prompt and essential support when it matters most. Thank you.
Thank you so much for your testimony. Recognizing Madam Vice Chair.
Thank you so much, Chair. And Thank you all for your testimony. Mr. Schultz, I want to thank you. Many of your tabling events have been in and near my district and my community, and I want to thank you so much for your bravery, for sharing, and for all that you do. Thank you. Thank you, Chair.
Thank you. I think this panel, as well as all of the panels that we will hear today, really illustrate the importance of these funds and saving lives. So thank you. Seeing no further questions from the subcommittee for this panel, we'll call upon our next one. The next one is Michelle Livshin with On Our Own of Maryland, Inc. Demetrios Kavathas with Healthport. Adrian Bridenstine with Behavioral Health System Baltimore. And Nikki Highsmith-Vernick with the Horizon Foundation. Okay, and you can begin when you're ready. Thank you.
Thank you, members of the committee and the administration, for the opportunity to speak today. I'm Michelle Livshin with On Our Own of Maryland. We represent an affiliated statewide network of more than 20 peer-operated wellness and recovery centers funded through BHA. Last year, our network served well over 7,000 people living with serious mental health or substance use needs. And we are here today urging you to maintain funding in the BHA budget for non-Medicaid grant-funded community behavioral health services and for crisis services. Non-Medicaid grant-funded services like ours are an integral and cost-effective component of the continuum of care. People who are unable to access traditional services due to fear, stigma, trauma, or financial barriers are welcome through our doors. No referral, paperwork, or insurance card required. Staff with lived experience and specialized training help you meet your basic needs, learn about wellness, self-help skills, connect with treatment, find housing, education, and employment. We de-escalate crises, we divert hospitalizations, and we create hope, trust, and healing. Most of our centers run an annual award of less than $200,000 per year. We do a lot with a little, and we are so grateful for the past provider rate increases which boosted our budgets. But like our clinical colleagues, we are still understaffed and overloaded with people seeking support in these uncertain times. When other programs get cut, are full, or closed down, peer support has always been there. As the state seeks a balanced budget, grant-funded community programs like ours, much like crisis services, fill the gaps in our systems of care with creativity, flexibility, and innovation, and achieve great returns on investment. Peer support turns barriers into opportunities, crisis into recovery, and struggle into purpose. And we are an integral part to supporting our workforce challenges. Please keep behavioral health funding whole, and thank you.
Thank you. Go ahead.
Hi, my name is Dimitri Kavathas. I am the CEO of Healthport. We operate on the lower shore of the Eastern Shore, and we've been around for 45 years, and we are one of your CCBHCs. And we're here today to tell you that we would like you to consider keeping CCBHCs in the system of Maryland. I'm also a board member of the National Council for Mental Wellbeing, so I'm exposed to the national level of over 500 CCBHCs across the country, and have seen the impact of their care in places like Texas, Oklahoma, Kansas, Indiana, New York, and it is a very important program. And I want to commend the department for keeping the funding for the value-based programming, the $600,000, because I think what it does, it also aligns with CCBHCs. CCBHCs are a value-based program. And in fact, what it's done for us is being able to expand our services to serve 2,000 people in the community. I think also to keep in mind that our data is showing through the Maryland CRISP program that we're having significant savings for the care we're doing. So if you look at 12 months prior to our interventions to 12 months after our interventions, we have a savings of over $2 million. So I think that with the reduction of 48% of hospital costs, that we're showing a trend that will really be able to allow us to afford the CCBHC model and improve the quality of the care we're providing to the citizens of Maryland. So I would really like to be very mindful of the budget environment we're in right now. I know things are tight, and I want to make a common sense suggestion. Let's accept the money of $926,053, 926,053 from the federal government. Let's plan this out, and let's give the department a window to implement this plan. Let's give them some room to do that. Thank you.
Good afternoon. I appreciate the opportunity to testify today. I am Nikki Highsmith-Vernick, and I'm President and CEO of the Horizon Foundation. We are Howard County's community health foundation and the largest independent health philanthropy in Maryland. I'm here to testify today about the protection of 988 funding. We worked very closely as a philanthropic partner to support many of the advocates in this room to build out the full continuum of behavioral health crisis services and to secure a dedicated revenue source for 988. So I appreciate the question from Delegate McCaskill to clarify the 988 funds, and I appreciate the clarification from the Deputy Secretary about this dedicated revenue source that so many of us worked hard to achieve. So thank you. But while I'm here, also thank you for the crisis funding grant, which is operated by Way Station, Shepherd Pratt in Howard County, and to ask you to fully support school-based mental health services, which I know you'll talk about at a later date. We are part of the hub in Howard County that is receiving funding from the consortium supporting our local hub, and we hope that all of the mental health funding for our students gets restored. Thank you.
Good afternoon. Good afternoon. I'm Adrienne Bridenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. For those who don't know us, Behavioral Health System Baltimore, or BHSB, we are a nonprofit organization, and we are one of the local behavioral health authorities in the state. We're responsible for overseeing that full continuum of care of behavioral health services in our community. One of the things we are also responsible for that we do in partnership with BHA is overseeing the 988 helpline. And I just want to say thank you to this committee for their work to secure the funding over the years for the 988 helpline. I'm grateful to hear today that we can look forward to see that funding in the supplemental budget. Maryland has a really strong 988 helpline, and it's going to be there for people when we need it most because of all the work of the advocates, the department, and those of you in this room. In Central Maryland, our 988 helpline picks up the phone in 17 seconds. So we are there when people need us. So I just want to express my thanks and gratitude for everyone in this room for their work that they do on that. Also want to thank the department for including the $5 million of the crisis response grant in the FY26 budget. We use that also in the city to deploy our mobile crisis teams overnight. And then finally, our ask of the committee is that you do protect that 1% rate increase for behavioral health services for all the reasons my colleagues mentioned earlier. Thank you for the opportunity today.
Thank you so much for the work that you all are doing. Any questions from our subcommittee members? Thank you. Seeing none, we will move. Whoops. Sorry. Seeing none, we will move to our final panel. Diane Lane with Chesapeake Voyagers, Inc., and Jane Krienke with the Maryland Hospital Association. Oh, perfect. Okay. And is Jane here? Great. Okay. Welcome.
Good afternoon. Good afternoon, Chair Shetty and Vice Chair Jones, members of the subcommittee. My name is Jane Krienke. I'm here on behalf of the Maryland Hospital Association, just to provide information related to BHA's budget. As has been mentioned several times, pediatric hospital overstays are a challenge we're facing every day in Maryland's hospitals. So this means there are children and youth in our emergency departments and inpatient units who have been medically cleared for discharge, but they have no place to go. So I want to thank Chair Shetty for your engagement in these conversations. It's really important to us. Upstairs, they're actually hearing this bill that we hope will provide a solution. Just to provide some data, as of February 14th, there are approximately 59 children across Maryland who are stuck in hospitals. Nearly 29% of them were in emergency departments. Approximately 73% of these youth are between 16 and 17, so school-aged youth. Approximately 39% are involved with Department of Human Services or local DSS, either in care and custody or they have an open case. Approximately 63% are waiting for a residential treatment center, a foster home, or group home. And then the average length of stay in an inpatient unit after being cleared for discharge is about 40 days. So these are long stays for some of these youth. Children in foster care tend to face even longer delays, and some end up living in hospitals. There is legislation, as I mentioned, House Bill 962, Senate Bill 696, which seeks to expand behavioral health capacity. Again, a lot of these youth are waiting for RTC beds. Although there's a $5 million fiscal note associated with this proposed bill, We think there are several potential funding sources and ways to offset the costs. As in the BHA budget, or in the operating budget, there's a recommendation to decrease funding for the Interagency Hospital Overstay Initiative by $1.9 million. I'm learning more about that fund. We think in case these funds could be used for RTCs, we'd urge the committee not to cut that funding or any funding that goes to support hospital discharge initiatives. According to the MHCC, Maryland Healthcare Commission, there are at least 17 licensed but unstaffed RICAs in the state, so state-run RTCs. Most of the youth, again, are waiting for those types of beds, so investment in that type of bed could make a huge difference for our overstay population. The Department of Human Services spends a lot of money to send children out of state. In FY23, they spent $3.3 million to send children to out-of-state RTCs. In FY24, $4.8 million. So in thinking about cost savings for the state, if we can open up more beds here in Maryland, we can both keep children and family together and then have cost savings for the state. We're happy to provide additional information and work with the subcommittee and appreciate your time.
Thank you so much for your testimony and your continued partnership to identify some better opportunities for these young people.
Sure.
Are there questions from the subcommittee? Okay, seeing none, thank you. That concludes our advocate panel and our budget hearing today and the Behavioral Health Administration. We will see a lot of people on Friday for our next subcommittee hearing on DDA. Thank you.